you know, from the point of view of a clinician who's worked with pituitary patients for a long time, it's, you know, I can't thank people enough for the work that you do. So if I can have the next slide, please. Thank you, Kim. So these are the topics that I thought we could cover. So just starting out with an introduction to prolactin as a hormone, what it's meant to do in the body, and how it's regulated and how it affects other hormones. So that's what medically we called physiology, as in how things work normally. Then thinking a bit about if you have high levels of prolactin when you know, that's not meant to be happening, what could cause that and what impact that has, how we in the clinic would investigate that and how it can be treated. And then, because I think things are always easier if you have some clinical illustrations, I'm going to, you know, just give you some clinical illustrations to illustrate the things that I've talked about. And then obviously time for questions at the end. Thanks, Kim. Next slide, please. So obviously the clue is in the name. So prolactin, you can obviously tell that this is to do with lactation and promoting lactation. So on the left there's panels of breasts, and I mean, it sounds a bit perverse, but if you think about breasts, the most extraordinary tissue, and there's the slides from rat breast tissue, but you can see that from the sort of baby rats where they just have these you can see the little sort of narrow ducts there and not much else. And then when the rat becomes pregnant, you can see you're getting more ducts and you're getting little lobules. Then when there's actual lactation, so production of breast milk, you can see how, you know, full those lobules are. And then obviously afterwards, the breasts then have to go back to a more normal sort of pattern. So that incredible sort of change that can go on within the breast tissue. And both the breast development and also the production of milk, both the production and lactation, actually sort of, you know, breastfeeding, is regulated by prolactin and also by other hormones. So other hormones that are involved, hormones like estrogen, progesterone, and also hormone oxytocin. But as I say, the focus of this talk is more to do with the prolactin. Thanks, Kim. Next slide. Thank you. So prolactin is produced obviously by the pituitary, more specifically by cells called lactotroph cells. And again, that, you know, the clue's in the name, and that's in the anterior part of the pituitary. And all of the pituitary hormones have complex regulatory pathways to make sure that we have just the right amount. And I've simplified things a little bit, obviously, but in general, estrogen will stimulate production of prolactin, and dopamine, which is a neurotransmitter, is quite a key inhibitor of prolactin production. And that's useful because a lot of the medication that we use works through that dopamine inhibition of prolactin production. So we sort of harness that physiology when we're treating people who have prolactinomas, for example. So there are times in life when prolactin levels are naturally high. This is when prolactin is doing what it's born to do. So that's, for example, in pregnancy or when someone's breastfeeding. And the graph there, it is not in UK units, I'm afraid, but it's just to show across the 40 weeks of pregnancy how prolactin levels naturally rise. And as I say, that's prolactin's time to shine. So it's time in the sun. So that's all how prolactin works nice and normally. Thank you. Next slide, Kim. Thank you. So what effect does prolactin have on other hormones? And again, we're still thinking about the normal physiology, so what happens normally in our bodies. So a lot of people will be familiar with the fact that once a woman has had a baby and is breastfeeding, very frequently there'll be a gap and her menstrual periods won't return during that time whilst she's breastfeeding. Now, medically, we always do advise people not to rely on that because it's not a very efficient contraceptive, but you can think of it as nature's sort of natural way of trying to space out childbirth a little bit. So prolactin is important in the mechanism for this. So when prolactin levels are high, essentially all of the levels of your ovarian axis, which is from your hypothalamus to the pituitary to the ovary itself, are sort of damped down in their production of hormones. So all of the sort of tiers of regulation of the menstrual cycle and of ovulation are all damped down by those high prolactin levels whilst you're breastfeeding. So during that time, a woman's periods will generally not resume and she generally won't be ovulating. So also this shows us a little bit why some of the problems can arise if somebody's prolactin levels are high at a time when they're not meant to be high, because the high levels of prolactin will have a similar effect in terms of lowering levels of estrogen and testosterone in a man and suppressing ovulation. So the sort of physiological mechanism gives us an understanding of what happens when prolactin is high at a time when it's actually not meant to be. Thanks, Kim. Next slide, please. So this is just a little bit of stuff just for interest really, but I think, we think of prolactin in terms of milk production and breast tissue, but it does have a number of other roles in the body. So if you think about, a person, a woman, if she thinks she's pregnant, she might go out and do a pregnancy test. But obviously it's very important that mammals who wouldn't go out and buy a pregnancy test also know if they're pregnant. And mammals do know if they have ovulated, obviously if an egg's implanted, if they're pregnant. And this is through the effect of prolactin together with other hormones. Next slide, please. Thank you, Kim. So if you think about what we do as mammals, we have quite a we invest a lot in our offspring. So metabolically, we invest a lot in our offspring. And milk production from the maternal point of view is a big investment in terms of calories, and time. So you're investing a lot in your offspring. The babies are born at quite a vulnerable stage. So they're born quite vulnerable and they have this ongoing milk breastfeeding, which supports particularly brain development. So obviously that's a strategy that mammals use for success, that milk production. But to go with that, you do need to have changes in the mother's brain so that she will nurture and care for the baby and adapt her behavior so that she's not just producing milk, but there's a sort of holistic care for the baby. And I guess it's unsurprising that similar hormones are involved in those two strategies. Next slide, please. So this slide is a bit busy, but what it's basically telling us is that the prolactin is not just supporting milk production, but it's supporting other adaptations for pregnancy. And that may be metabolic adaptations. It's also to do with behavioral adaptations, as I say, sort of lowering anxiety levels, little mice and rats think about nesting and finding their little nest. Suppressing stress responses and that sort of thing. So similar hormones are involved both in the milk production and the sort of adaptations to the mother's brain and also body. But let's get back to more of a sort of disease pituitary focus. So next slide, please. Thank you, Kim. So we've talked about high levels of prolactin when somebody's pregnant or breastfeeding. The other thing to know about prolactin is it is what we would call a stress hormone. So levels will go up if you're stressed or worried. And when we talk about stress medically, it can be something as simple as worrying about a blood test, anticipation of a blood test. Somebody can't find your vein. That can put prolactin levels up a little. So quite commonly we'll get referrals with a sort of modestly high prolactin. And if you can get the blood test repeated in slightly more relaxed circumstances, if it was just a stress response, then you'll see a reassuring repeat result and you'll be able to reassure the patient that there's nothing actually to worry about. It was just that they were a little bit stressed when they had that first blood test. But in terms of other causes of a high prolactin, obviously we'll focus particularly in this discussion about pituitary disease. And so that's both prolactinomas and non-functioning adenomas, and we'll come back to that. We know also that some medications that are used to treat other conditions have a side effect of elevating the prolactin, and that includes some antipsychotic and antidepressant medication and some drugs used to treat nausea and vertigo. So again, when we're referred somebody with a high prolactin, we'll want to check if there's any obvious medication that they're taking that could be causing that high prolactin level. And then there are some other much rarer causes of a high prolactin, some women with a condition called polycystic ovary syndrome, which is quite a common condition causing erratic periods, may have a slightly high prolactin, and people who've got very severe underactive thyroid can have a slightly high prolactin, but those are all sort of slightly rarer causes that we won't focus on. Thank you, Kim. Next slide. So coming then to the pituitary. So in terms of pituitary diseases that cause high levels of prolactin, so you've got prolactinomas and non-functioning adenomas. So prolactinomas are benign, as people know. They're very, very, very seldom anything other than benign, but they overproduce prolactin. And slightly arbitrarily, as you may or may not know, in pituitary adenomas, we call a microadenoma something that's less than 1 centimetre, and a macroadenoma something that is greater than 1 centimetre, and that is in diameter. And microprolactinomas can be really teeny weeny. Sometimes they're so small that they just look like a slightly asymmetric pituitary gland on a scan. You can't even see a precise adenoma or swelling there. And we'll look at some scans a bit later on. You may wonder about how a non-functioning adenoma could cause a high prolactin, because that, by definition, it's not functioning, so it's not making prolactin itself. But what can happen here is that by compressing the pituitary stalk that joins the pituitary to the hypothalamus and the brain, the pituitary doesn't receive that dopamine. And if you remember, dopamine normally inhibits or stops prolactin release. So if you take the brake off, as it were, you're stopping that normal dopamine restraint just literally by a compression of the stalk. And that can also cause a slightly high level of prolactin. And it is important as an endocrinologist, that we take care to be sure whether we're dealing with a prolactinoma or a non-functioning adenoma, because the treatment is different for those two conditions. And again, I'm going to include some clinical examples of each. Thank you, Kim. So what are the effects when you have a high prolactin at a time when it's not meant to be high? So non-physiological high levels of prolactin. So there's slightly different presentations in women and men. So in women, typically it can cause either scanty or absent menstrual periods. It can affect the sex drive or the libido and cause a loss of sex drive or vaginal dryness, which can cause difficulty with intercourse. It can cause milk production from the breasts at a time when you're not trying to breastfeed. And it can cause difficulty conceiving because it's stopping you ovulating. So women may not have all of those, 4 different sorts of symptoms. They may have 1 or 2, but that's the sort of full house, but people may not present with everything. It is quite common for women with a prolactinoma to present shortly after stopping taking the contraceptive pill. And that's not because the contraceptive pill is caused this problem. It's because when a woman is on a combined contraceptive pill, she will get a regular withdrawal bleed, and she won't really know what's happening to her own natural cycle underneath that. Now that doesn't matter, and obviously a combined oral contraceptive pill is effective contraception, but it is often the case that women will take it from teenage time until their 20s when they're trying to conceive, and then stop it, and then sometimes these problems will become manifest that a woman might not have been aware of before. So in men, the presentation is a bit less obvious in some ways. So again, it can present with a reduced sex drive or problems with erectile function. And because those are slightly vaguer symptoms, men will often present later. Now, in both men and women, if a prolactinoma becomes big, becomes a macroprolactinoma, then they will present with symptoms because of the effect of that adenoma and the space it's taking up in the pituitary. So that may be visual symptoms, so loss of vision, and I'll show you a sort of a picture of how that can affect your vision. It can be headaches, or it can be symptoms because the rest of the pituitary is being squashed and not functioning properly. So men will sometimes present with those sort of symptoms due to the space being occupied by the adenoma, whereas women will often present with a smaller adenoma because of the effect it has on periods and milk production and fertility. And in both men and women, if the prolactinoma lowers the levels of estrogen in women or testosterone in men, in the long term, there is an increased risk of osteoporosis, which is bones becoming more brittle and liable to fracture. So that's something, again, medically that we factor in when we're assessing patients, and we just think a bit about bone health as well. Thank you, Kim. Next slide. So when somebody comes along to clinic, and they'll often be referred because the GP has found a slightly high prolactin level. We'll always think about pregnancy. We don't want to be caught out getting into all sorts of complex tests when someone's actually pregnant. We'll do a few basic sort of screening blood tests to be sure someone's got normal kidney function, so they're clearing prolactin normally, normal liver function tests. We'll check their thyroid, partly because that's part of your pituitary profile, and partly because a very underactive thyroid can cause a high prolactin. We'll often repeat the prolactin, particularly if it was only slightly elevated, and that's because of that stress effect I mentioned. So you want to be sure that you're looking at a genuine result. The LH and FSH are the hormones from the pituitary that regulate the testosterone and estrogen production, and we'll measure those. It will measure testosterone in men. In women, the menstrual history gives you usually the information you need without additionally having to measure the estrogen levels. And then depending on the results of those tests, we may then be going to the next step and looking at our pituitary with an MRI scan and looking to see if we can see an adenoma there. And then if we do find a macroadenoma, so something that's greater than 1 centimeter diameter that might be affecting the visual pathways, then we'll go on to assess somebody's visual fields more formally, and I'll show you how we do that, and obviously have a more detailed look at the rest of their pituitary function tests and check that the rest of the pituitary is not being compromised by that larger adenoma. Thank you, Kim. So what are the aims of our treatment? The treatment aims do depend a bit on the cause, obviously, and also on the effects that it's having on somebody's health. And sometimes you can make a diagnosis and you don't have to implement any treatment. And again, in the clinical examples, I'll show you some examples where confirming the diagnosis was all that was needed. But obviously, depending on what somebody's priorities are, they may be wanting you to restore fertility, if that's their priority. They may be wanting you to stop the milk production, because that's just a sort of bothersome thing. You might want to restore someone's menstrual cycle and their sexual function. And that, obviously sexual function applies in men and in women. And if it's a macroadenoma, you do want to shrink that down, partly to restore the vision and stop any compromise to the visual pathways, and partly to recover the function of the rest of the pituitary gland if that's been compromised or been affected. So those are your general overall aims. Thanks, Kim. So one of the drugs that we can use to treat a prolactinoma is a drug called cabergoline. So cabergoline is a drug people may have come across, and some of you, I'm sure, might be treated with this. So cabergoline is a long-acting tablet. So quite unusually, it only needs to be taken once or twice per week. So that's something we always have to remind people of, because people get into a habit of daily medication. It's a tablet that can have some side effects. So the more common side effects is sometimes it can make people feel a bit dizzy, sometimes a bit nauseous. Sometimes in some patients, it can cause headaches. We often find that if people take it with food and sort of late at night before bed, that can minimize the side effects. And with the dosing, we start slowly with a low dose, and then we adjust depending on the effect that the medication is having, the blood test results and the scans. And we now know that particularly in people with a microprolactinoma, so the small prolactinomas, cabergoline treatment can actually result in remission. So remission being that you could stop the treatment and the prolactinoma won't come back again and won't recur. So we think in terms of, for example, a 2-year course of treatment. And if you've seen a really nice response in terms of the blood tests and the scans, you can often then pause the cabergoline and then keep people under assessment to check if there's any signs of things coming back again. So cabergoline is a tablet that's extremely effective. It can have some sort of rarer side effects, and because they are side effects that are all over the sort of information leaflets and things we need to think about, even rare side effects we obviously discuss with patients. So there was quite a bit of concern when cabergoline was used in much older patients with Parkinson's disease, that in some of those patients they saw some heart valve damage. Now, when people have done a lot of really proactive research looking at patients treated with cabergoline at the smaller doses we use for prolactinomas, they have really not found any particularly worrisome outcomes at all in terms of the heart valves. But this sort of slight worry has stuck with the drug. So you may find that you're recommended to have an echocardiogram, which is a simple ultrasound scan of the heart to look at the valves and check that they look normal, because some people would have a heart valve problem they were completely unaware of. And if taking the tablet, and this would be extremely unusual, you developed new symptoms like breathlessness or ankle swelling, clearly that would be something to discuss with your doctor and your endocrinologist. But it is felt to be extremely rare, and people have looked proactively for it in patients treated for prolactinomas. Probably slightly more commonly, though still very rare, are psychiatric disturbances in patients on cabergoline. And these are slightly odd, and they are sort of impulsive, almost like your normal restraints have been removed. So it may, for example, be a sudden desire to gamble or a very increased sex drive. And it kind of sounds, well, maybe that would be fun. But if it happens to people, it's really, really not fun. It's really intrusive, and it can cause, obviously significantly disturb their relationships and their work life. So we do always discuss this with patients, again, even though it's very rare, so that if the patient or their nearest and dearest were worried, then obviously they can stop the medication and discuss any concerns that they might have. So these are rare things, not things to be overly worried about, but things that you may well find are discussed with you on starting this new medication. Thank you, Kim. So in terms of pregnancy and breastfeeding, so cabergoline is very effective and will often restore fertility very quickly. So again, that's a conversation we'll have with a woman who's trying to conceive and we're starting cabergoline. Sometimes people will conceive even before they've seen a natural period. So that's brilliant. But obviously, if they don't want that to happen, they need to think a bit about contraception straight away. If someone's being treated for a microprolactinoma, one of the less than 1 centimetre ones, then all we say is take the cabergoline. Once you confirm a pregnancy, a positive pregnancy test, then you can stop taking it. Cabergoline is not actually dangerous in pregnancy, but obviously if a drug is not needed in pregnancy, then we don't want people to be taking any unnecessary medication in pregnancy. If people have a macroprolactinoma, so that's one of the bigger prolactinomas, then in relation to pregnancy and advice about treatment, that would be on a sort of individualized basis with their endocrinologist. And obviously, sometimes there are other causes of subfertility. So, when you're thinking about fertility, hyperlactin may be one cause in the woman, but one always has to think about causes in relation to the partner or other causes if the cabergoline doesn't restore fertility. In relation to breastfeeding, so cabergoline would obviously stop you breastfeeding, it would stop the milk production. So we would never resume cabergoline treatment whilst a woman was breastfeeding. So what we do is we feel, nice and relaxed. We advise people to breastfeed for as long as they want to breastfeed for. And then after they've stopped breastfeeding, we'll see what happens to their menstrual cycle and their prolactin levels. And curiously, but it is certainly a recognized phenomenon, some of the microprolactinomas, the small ones, disappear after a pregnancy. They just disappear and they never come back again. So that's part of the reason why we'd always reassess at that point before planning the next phase of treatment. And again, with macroprolactinomas, which are rarer, you would get individualized advice about breastfeeding from your endocrinologist. Thank you, Kim. So in terms of other options for treating prolactinomas, as I say, sometimes no treatment is required. Sometimes if the problem is, for example, a lack of periods in someone who's not wanting to conceive, or a low testosterone in a man, you can just replace that hormone, the estrogen or the testosterone, particularly if you're dealing with a very small prolactinoma and you're not worried about it taking up space. There are other similar drugs to cabergoline, bromocriptine and quinagalide that I won't go into, but they're broadly similar. And obviously somebody might need fertility treatment. As I say, if you haven't managed to restore fertility, then they may need other treatment options. Surgical treatment is available. Because we have tablets that work so well, in prolactinomas it's seldom necessary, but we do have some patients who just can't take the cabergoline due to side effects. And sometimes the prolactinoma doesn't respond to cabergoline treatment. And then you do, particularly obviously if it's a macroadenoma, need to think about surgical treatment. And as I said, if you find that this is not a prolactinoma at all, but it's actually a non-functioning adenoma, then that does need surgery if it's affecting vision or compressing the stalk. Thank you, Kim. So I thought I'd just finish with just a few clinical examples, because that can sometimes help make things clearer when it may not have been clear before. So thank you, Kim. We'll have the first slide. So this patient actually is an older patient who was referred because she had an abnormal head scan when she came into hospital, and she was found to have a macroprolactinoma and was treated with cabergoline. So if I can have the next slide, please. I've realized because I can't use my arrow, I'm going to have to describe this. So this is really just her baseline scan, and the one on the left is her head cut through from the nose to the back of the head. And the one on the right would have ears on either side if it included the ears. So they're just two different ways of slicing the brain. And right in the center of it, you can probably see a sort of roundish blob with two smaller white blobs inside it. Yes, brilliant, Kim. So that is a big prolactinoma. And it's actually the tiny little crescent you can see at the top of that blob that's being squished right up. It's almost disappeared, is the optic chiasm, the nerves from the eyes. So that's being completely squished by this big prolactinoma. And her prolactin was 15,000, with the normal range being up to 500. So we're very confident in our diagnosis. This is a macroprolactinoma. Next slide, please. Thank you, Kim. So this is her visual fields. And if you've been to Boots Specsavers or had a pituitary problem yourself, you'll have done these tests where the little red light is flashed in the distance and you have to say if you can see it. And the black parts are all the parts that this patient couldn't see. So you can see she had very restricted vision, both from her left eye and her right eye. And you could clearly see from the scan, that's because this adenoma was compressing her visual pathways, the nerves from the eyes to the back of the brain. Next slide, please. Thank you. So this is a before and after. So this is the view on the left, is the picture you saw before, nose at the front, back of the head at the left. And then if you look in the same place where that big circle was with the blobs inside, you can now just see almost like a little rind of tissue left there, a little upside down crescent moon. So you've just got like a little core of tissue left there. Now, the remarkable thing about this is this patient has had no surgery. She's had cabergoline treatment from December to April, so just a few months of cabergoline treatment. And marvelously, that whole macroprolactinoma has vanished away. Her visual pathways are now free. You can see nice clear black space, and her prolactin has come right down. Next slide, please. Thank you, Kim. And this is just the ear-to-ear vision. So again, the picture on the left is the pre-treatment one I showed you before, ears on either side. And on the right, you can see where that big central blob was. It's vanished away. You've just got a little rind of tissue. You've got clear black space where you're between that and the optic chiasm. So, you know, an excellent result. Next slide, please. And I'm sorry, this is visual fields of the same patient, but done in a different way, which is always the way with clinical. This is proper clinical stuff, but essentially her visual fields are fully restored. So she can now has a full field of vision just as a result of that medical treatment with cabergoline. So that's obviously a really excellent result. Next slide, please. Thank you, Kim. So the next case, I just wanted to mention a different case. So this is a young woman who presented with 2.5 years of milk production. It always seems odd that people go on with these sort of slightly odd problems for quite a long time before they present for help. So she'd had this for quite a long time. She was taking the pill. She wasn't on any other medication and had had no previous problems with her health. So she had her prolactin measured twice. And on both occasions, it was elevated. So the upper limit of normal is about 500. And you can see her two readings there were, you know, they were elevated 1600 and 2000. So she had milk production, she was on the pill, and those were her prolactin levels. Next slide. Thank you, Kim. So her pituitary is within the fossa, and again, the side on the left is nose at the left and back of the head at the right, and the picture on the right is ears on either side. And again, if you look right in the middle with the pituitary gland, brilliant, yes. The little slightly darker bit, I don't know if you can convince yourself that there's a little darker bit within that pituitary gland, is a little microprolactinoma, exactly. So it's well behaved, it's sitting within the pituitary fossa, it hasn't expanded out of that bony dish, and that is a microprolactinoma, and that fits with her levels of prolactin. Thank you, Kim. Next slide. So we made the diagnosis. She wasn't interested in trying to conceive, so she could just continue taking the pill, which is giving her estrogen, so she's not going to be at risk of osteoporosis. Bizarrely, and you do have to have these slightly bizarre discussions with patients in clinic, if she does, when you get milk production from the breasts, obviously the temptation is to see if it's still happening, to kind of check for it, which is usually tweaking the nipples. And the way breasts are designed, every time you do that, they'll think that there's a baby on board and they'll start to make more milk. So if in this situation, you can encourage somebody just to stop checking and try to avoid all forms of nipple stimulation, then often it will settle down and the problem of the milk production will go away. But if not, she might require some cabergoline treatment. And she might also require cabergoline treatment if, when she stopped the pill, she was having difficulty conceiving. And obviously, again, with her after a pregnancy, she's one where you would reassess things when she stopped breastfeeding. So that's a patient with a microprolactinoma. Next slide, thank you. So this is another patient, Louise. So she presented with 8 months of no menstrual periods. So that was her presentation. Her periods had just stopped for the previous 8 months. She'd done quite a few pregnancy tests. They'd been negative. And again, she wasn't on any medication. She didn't have any particular medical problems in the past. She wanted to have children, but wasn't quite sort of ready to do so yet, but was concerned that her periods had stopped. And her prolactin measured twice was a bit elevated. So you've got levels there, 1400, 1700, with the upper limit of normal being about 500. So next slide, please. We've got her scans. So you should be getting experts in these, especially Kim, who's doing brilliant work with the arrow there. So you've got your pituitary there, and this is a picture you don't really want to see in this position because she has got a fairly sizable adenoma again there. And you can see it's extending up the sort of grayish area up out of the fossa exactly, and is also just compressing her chiasm, which is that little white line over the top there. So this is a situation where her slightly high prolactin is being caused by a non-functioning pituitary adenoma that's just pressing on the stalk and causing the high prolactin because it's stopping that dopamine being released. If this was a prolactinoma, as in all of those cells making prolactin, her prolactin levels will be much higher. So she's got a non-functioning adenoma. So next slide, please. Thank you, Kim. So in this case, we can't use cabergoline because although cabergoline would bring down the prolactin numbers, it won't shrink that swelling, and that swelling is compromising her vision. So she's somebody who we had to refer for pituitary surgery, transsphenoidal surgery, because if we left that alone, there would have been a risk to her vision from further growth of that adenoma. And obviously, ideally, although pituitary surgeons are wonderful and skillful, there would then be a risk to the rest of her pituitary function, including her chances of conceiving, which would be amenable to treatment, for example, ovulation induction, IVF. But, it would have been nicer if we'd found a prolactinoma, because that's much easier to treat with tablet treatment. But that's an example of a slightly high prolactin caused by a non-functioning pituitary adenoma. Next slide. Thank you, Kim. So Carol, just as a brief example, Carol was 48 and again presented with milk production from her breasts. She was still having a regular 4-weekly menstrual cycle, and she'd been troubled with a long history of anxiety and depression. And she was treated with a tablet called risperidone, which is quite a strong antipsychotic medication. And her GP had done her prolactin, done it twice, as is good practice, and it was significantly elevated. So you remember the upper limit of normal about 500. So her levels were over 3,000. So we did an MRI scan for Carol, and reassuringly, that was structurally normal. She had a normal pituitary. Next slide. Thank you, Kim. So in this case, we were able to reassure Carol that her high prolactin was a side effect of her medication. No need to change the medication because she was having regular menstrual cycle, and risperidone is sometimes just necessary to treat somebody's mental health. You don't want to change that and risk their mental health. So as I say, the regular periods is reassuring. And again, hopefully, if she's able to avoid the nipple stimulation and the checking, that milk production problem will settle down and go away again. So similar advice. Thank you, Kim. Next slide, please. So this is my last slide. This one you have to guess the diagnosis because hopefully you've been concentrating. So Charlotte, 27. So she was sent to the endocrine clinic. She'd had 6 months without any menstrual periods, and she'd noticed symptoms of feeling quite tired and bloated, and she wasn't on any regular medication, and her prolactin again was elevated at 3,000, upper limit of normal about 500. I don't know if anybody wants to suggest what was going on here.
Macroprolactinoma?
Well, actually, this was something simpler than that. So a 27-year-old, if you weren't thinking about, if you were her GP and she said, I hadn't had a period, I'm a bit tired and bloaty, she was pregnant. So anyway, so one always has to think about the physiological causes because sometimes patients don't think of it themselves, and you can get down a sort of whole endocrine avenue without remembering that actually, prolactin can sometimes be doing what it's born to do, as in pregnancy and breastfeeding. So that was Charlotte. Next slide. Thank you, Kim. So that's the end of what I had planned to say, but I'm more than happy to try to help with any questions if I can. Thank you very much for your attention.